The effects of advanced myofascial remodeling on fascial restriction, pelvic mobility, and low back pain. Abstract. Presented by Ejiro Pekulia Oyowe from Manual Osteopathic College of Canada, MOCC. Hypothesis-based case study 4. Advanced myofascial remodeling. Low back pain is one of the most common musculoskeletal conditions encountered in clinical practice and is frequently associated with reduced fascial mobility, altered pelvic mechanics, and impaired functional movement. This hypothesis-based case study investigated whether advanced myofascial remodeling could reduce fascial restriction, improve pelvic mobility, and decrease low back pain in an adult client who is presenting with persistent lumbopelvic dysfunction. The hypothesis proposed that restoring normal fascial mobility through advanced myofascial remodeling would decrease fascial restriction, improve pelvic mobility, reduce tissue tension, and relieve lower back pain immediately following treatment. This case study includes an abstract, introduction, methods, results, discussion, conclusion, and bibliography. A comprehensive health history was completed before treatment, and appropriate contraindications were excluded. The assessment includes postural observation, global movement assessment, tissue palpation, fascial listening, strain pattern assessment, pelvic mobility assessment, and myofascial evaluation to identify the primary fascial restriction contributing to the client's symptoms. The primary findings include restricted fascial mobility involving the thoracolumbar fascia, pelvic fascia, and associated myofascial structures. Treatment consisted of advanced myofascial remodeling techniques directed at restoring normal fascial mobility, improved tissue glide, reducing fascial tension, and improving pelvic movement. Reassessment was completed immediately following treatment using the same assessment procedures. Following treatment, improvements were observed in fascial mobility, tissue glide, pelvic mobility, and overall movement quality. The client also reported reduced low back pain, decreased tissue tightness, and improved comfort during standing, walking, sitting, and functional activities. These findings supported the proposed hypothesis that advanced myofascial remodeling may improve fascial mobility and contribute to improved musculoskeletal functions. Although this case study involved one client and one treatment section, the findings suggest that advanced myofascial remodeling may be an effective component of a comprehensive manual osteopathic treatment plan. Further research involving larger sample size and longer follow-up periods is required or recommended to strengthen the current evidence supporting advanced myofascial remodeling in clinical practice. Introduction. Low back pain is one of the most common musculoskeletal disorders worldwide and is a leading cause of pain, disability, and reduced functional ability. It affects individuals of all ages and may interfere with work, daily activities, and overall quality of life. In many cases, lower back pain is associated with fascial restriction, reduced tissue mobility, muscle imbalance, and altered pelvic mechanics. Identifying and treating these fascial dysfunctions is an important part of manual osteopathic therapy. The fascial system is a continuous connective tissue network that surrounds and supports muscles, joints, nerves, blood vessels, and internal organs. Healthy fascia allows normal movement, force transmission, and tissue glide throughout the body. However, trauma, repetitive strain, prolonged poor posture, inflammation, and poor injuries may result in fascial restrictions. These restrictions can reduce tissue mobility, alter movement patterns, increase mechanical stress, and contribute to persistent pain and dysfunction. Advanced myofascial remodeling is a manual osteopathic therapy approach designed to restore normal fascial mobility, improve tissue glide, reduce abnormal tension, and improve the relationship between structure and function. By identifying areas of fascial restriction and applying specific remodeling techniques, the therapies aim to restore balanced movement throughout the body. Current evidence suggests that myofascial techniques may reduce pain, improve range of motion, enhance tissue flexibility, and improve functional outcomes when incorporated into a comprehensive treatment plan, although further high-quality research is still required. The client presented in this case study with low back pain, reduced pelvic mobility, and widespread fascial restriction that is affecting normal movement. A comprehensive health history and osteopathic assessment were completed to identify the primary fascial dysfunction which is contributing to the client's symptoms. Postural assessment, tissue palpation, fascial listening, pelvic mobility assessment, and myofascial evaluation identified significant fascial restriction involving thoracolumbar fascia and pelvic fascial system. The hypothesis of this case study was that advanced myofascial remodeling directed at the identified fascial restrictions would restore normal tissue mobility, improve pelvic mobility, reduce fascial tension, decrease low back pain, and improve overall function immediately following treatment. Before treatment, contraindications were ruled out, informed consent was obtained, and client was educated regarding the proposed treatment, expected benefit, possible risks, and home care recommendations. Short-term treatment goals included reducing pain, improving fascial mobility, restoring pelvic movement, and decreasing tissue restriction. Long-term goals focus on maintaining normal movement patterns, preventing recurrence, improving functional performance, and enhancing overall quality of life. Results. The findings from this assessment and reassessment supported the proposed hypothesis that advanced myofascial remodeling may improve fascial mobility, restore pelvic movement, and reduce low back pain. Before treatment, assessment demonstrated significant fascial restriction involving the thoracolumbar fascia and pelvic fascia system. Tissue palpation revealed increased fascial tension, reduced tissue glide, and decreased mobility throughout the affected region. Pelvic movement was restricted, and the client reported discomfort during prolonged sitting, standing, walking, and functional activities. Following advanced myofascial remodeling treatment, reassessment demonstrated improved fascial mobility, smoother tissue glide, reduced fascial tension, and improved pelvic mobility. Functional movement became less restricted, and tissue compliance improved throughout the lumbar and pelvic regions. The client also reported a noticeable reduction in low back pain, reduced feeling of tightness, and improved comfort during standing, walking, sitting, and daily activities. Both the objective assessment findings and the client's subjective feedback demonstrated immediate clinical improvement following the treatment. And overall, this finding supports the proposed hypothesis that restoring fascial mobility through advanced myofascial remodeling may positively influence pelvic mobility, reduce tissue mobility, and improve functional outcome in an individual who is presenting with low back pain. Discussion. This hypothesis-based case study investigated the effect of advanced myofascial remodeling on fascial restriction, pelvic mobility, and low back pain. The findings supported the proposed hypothesis by demonstrating immediate improvement in tissue mobility, fascial tension, pelvic movement, and the client's overall comfort following treatment. One of the most important findings was the improvement in fascial mobility after treatment. And before intervention, the client presented with significant fascial restriction affecting the thoracolumbar fascia and pelvic fascial system. These restrictions were associated with reduced tissue glide, decreased pelvic mobility, and low back pain. Following treatment, reassessment demonstrated improved tissue mobility, reduced fascial tension, and better movement throughout the lumbar and pelvic regions. These findings suggest that restoring fascial mobility may improve normal movement patterns and reduce mechanical stress that is placed on surrounding tissues. The client also reported a reduction in low back pain and a noticeable decrease in tissue tightness. Improvement in pain was accompanied by better tolerance to standing, walking, sitting, and other daily activities. Although pain is a subjective experience, the improvement reported by the client corresponded with the objective changes observed during reassessment, including improved tissue glide and pelvic mobility. Another important finding was the improvement in pelvic mobility. Fascial restrictions surrounding the pelvis may influence posture, movement efficacy, and load transfer through the lumbar pelvic region. Following treatment, pelvic movement appeared smoother and more symmetrical, suggesting that reducing fascial restriction may contribute to improved biomechanical function. Although the findings were encouraging, this case study has several limitations. The study involved only one client and a single treatment section, making it difficult to generalize the findings to a larger population. In addition, reassessment was performed immediately after treatment. Therefore, the long-term effect of advanced myofascial remodeling could not be determined. Future studies involving larger sample size and multiple treatment sections are recommended. The client was advised to continue gentle stretching exercise, remain physically active, maintain adequate hydration, improve postural awareness, and avoid prolonged static positions. A home care exercise program was recommended to support fascial mobility and maintain treatment outcomes. Follow-up treatment sections were also recommended to continue improving tissue mobility and monitor progress over time. This case study also highlighted the importance of collaborative healthcare. If symptoms fail to improve or new findings develop, referrals to client's family physician or other appropriate healthcare professionals would be considered. Working alongside physiotherapists, massage therapists, chiropractors, and exercise specialists may provide a more comprehensive approach to managing persistent lower back pain. From the client perspective, treatment resulted in reduced pain, improved fascial mobility, better pelvic movement, and greater ease during daily activities. From the therapist's perspective, this case study strengthens clinical reasoning, improves palpation skills, and reinforces the importance of identifying fascial restriction as contributing factors to musculoskeletal dysfunction. It also emphasizes the value of reassessment in measuring treatment effectiveness and guiding future decision making. Overall, this case study supports the use of advanced myofascial remodeling as part of a comprehensive manual osteopathic therapy treatment plan. Although additional research is required, the findings suggest that improving fascial mobility may positively influence pelvic movement, reduce pain, and improve functional performance. Conclusion: this hypothesis-based case study investigated the effect of advanced myofascial remodeling on fascial restriction, pelvic mobility, and low back pain. The purpose of this study was to determine whether improving fascial mobility could reduce tissue restriction, improve pelvic movement, decrease pain, and enhance functional ability. A comprehensive osteopathic assessment was completed before treatment to identify the primary fascial restriction contributing to the client's symptoms. Advanced myofascial remodeling techniques were then applied, followed by immediate reassessment in the same assessment procedures. The result demonstrated improvement in fascial mobility, tissue glide, pelvic mobility, and lower back pain, supporting the proposed hypothesis. Although positive outcomes were observed, this case study involved only one client and one treatment section. Therefore, the findings cannot be generalized to all individuals presenting with similar conditions. Further research involving larger sample sizes, repeated treatment sections, and long-term follow-up is recommended to strengthen the current evidence supporting advanced myofascial remodeling. This case study strengthens the therapist's understanding of fascial assessment, clinical reasoning, and treatment planning. It also reinforces the importance of comprehensive assessment, individualized care, reassessment, and evidence-informed practice in the management of musculoskeletal dysfunction. Bibliography: Barrel J.P. and Messier P. 2005, Visceral Manipulation, Sheila A.G., ed. edition, 2011. Foundation of Osteopathic Medicine, 3rd edition. Lipin, Court Williams, and Wickens. Drake, Arrow L. Vogue A.W. and Mitchell A.W.M. 2023. Gray's Anatomy for Students, 5th edition. Sylvia Findley T.W. Splish, Arrow and Chateau L. eds. 2012. Fascia, The Tension Network of the Human Body. Sylvia Mori K.L. Dali A.F. and Agu A.M.R. 2023. Clinical Oriented Anatomy, 9th edition. Walter Kluwer, Posadik P. and NSE, 2011. Osteopathic for musculoskeletal pain patients. A systemic review of randomized control trial, clinical rheumatology, 30, open bracket, 2, close bracket, 285-291. Scliff Arrow-Muller, DG, and Kingler, W, 2019. Fascia is able to actively contract and may thereby influence musculoskeletal dynamics. A review frontal in physiology, 10-336. Standring S. ed. 2001. Gray's Anatomy, The Anatomical Basic of Clinical Practice, 42nd edition. Xavier Stico, C. 2011. Functional Atlas of the Human Fascial System. Esivia. Ward Arrow CED. 2003. Foundation for Osteopathic Medicine, 2nd edition. Lippincott Williams and Wilkins.